condylar fractures and how to manage them. Fractures in thoroughbred racing with an annual incidence of 1.4%. These are older studies from Andy Faith, and it's also the most common fracture associated with race fatalities in the UK, but obviously not in US. At this research here, it was this, at the P1, the one that was more severe. But it's a very common injury we have to deal with when we're treating racehorses. And the occurrence of it, it's a disease that comes with speed. So racehorses are the fastest ones. Standardbreds are a little bit less, but the other, occasionally we find other horses, quarter horses, polo ponies, endurance horses, the horses that come up to some speed. So it's a speed injury, and it can occur in the training or during the race. And lateral condylar fracture are more common than medial ones, and front limbs are more affected than hind limbs. And there's always a discussion of the race course, if it turns left or right, whether this is related to the occurrence of fractured legs, whether they are lateral or medial or the left or the right leg. But to my knowledge, there's not yet a decision made on that topic. And the next thing is there is a variety of presentations radiographically of this condition. We start on the left side. This is called an incomplete fracture, meaning it's just one cortex involved and the fracture has not substantiated up to more proximally. And the next level would be complete non-displaced, and complete meaning the palmar, plantar, and the dorsal cortex are affected of the bone. And then you can have these displaced, so you have some sort of displacement. And usually these are lateral condylar fractures. And if you see these ones on where that starts to spiraling and you lose the lines here, these are propagating fractures, and they do occur mostly on the medial condyle and more on the hind limb than on the front limb. These are a challenge to treat. So radiographic diagnosis is the first thing you would do. And this is a specimen here that I got from Chris Ricks. And as it looks so clear on this bone, it's not so easy to pick this up on the radiograph. And this is an example of a short, incomplete fracture. And then the lateral condylar fracture, they tend to break out towards the lateral side and they become displaced. And the length of that spike is usually, the shortest one I saw is 50 millimeters up to 1.15 centimeters almost. And then that's also part of the problem here. These fractures, they can be displaced and long, and sometimes also associated with catastrophic failure if you have a weakness in the dorsal cortex. So what's the etiology of it? I think there's a lot of research done and continues to be done because it's disease that has evidence of a fatigue damage of the bone. And so this, when it comes to early monitoring, this is also interesting in condylar fractures. And but they have unique together that it's close to the sagittal ridge, even very close or a little bit. So it's lost my battery here. Okay, you can see close to the sagittal ridge, and then the next thing that can also be a little bit more on the condyle, and there are some stress risers, and they can be associated with subcondylar bone defects or a small crack in the bone that propagates. And this is typically of it. And the next thing is then, if there was done some research on the bone structure here, and it looks, if you do this, oh, now I got it, yeah, but it's really low battery. again. And then these samples show the layers that go sagittally up. They are well connected, but the different layers to each other are not well connected. So that's the reason why these trabecles can split longitudinally and propagate. And this is part of the unique architecture. And the majority of fractures, as I already said, are very close to the sagittal ridge. But, and this is also shown by Chris Ricks, he had a lot of these broken bones collected. If you have a substantial defect, they can also start from there and start cracking from there. So it's kind of a little bit of an idea about the pathology. And the clinical features are quite obvious. So you get a severely lame horse, you get a distended fetlock joint, and it's painful on palpation and on pressure of the MC3 or MT3. And once you have your diagnosis made on the race course, the next thing is how to immobilize it, to send it to a place where it can managed. And I know Ian Wright makes a strong point that, and this shows it nicely of the dead specimens here. It's out of his book, Fracture Repair in Horses. And you see if the limb is in extension, the fracture seems to reduces. And as long as you flex it, then it gets apart. And if you have a displaced fracture, this might be important. So he has made a strong point to immobilize those with the limb in extension, if you have your diagnosis. But in some cases, you don't have a diagnosis, and it's hard to say whether it's a split P1 or another disease. So then you would rather go for the typical type of having it straight bandaged. And the next point is, even if you suspect a condylar fracture, it's also important to make the right diagnosis. And this is assuming this is the line here that's slightly oblique. Then if you use it with a perpendicular beam, then you will miss that. And you just have possibly a little idea on it. And as soon as you change the angle a little bit of a few degrees, you hit exactly the fracture plane, and that shows you nicely the whole extent of this fracture. This is important. And therefore, you have to angle your beam and try several projections. If you, oops, that's the wrong way, yep. So, and the same is true in the dorsopalmar or dorsoplantar view. If you have this, it's exaggerated now. If you can hit the condyle in different planes, and if you're looking for pathology in the more dorsal aspect of the condyle, you use this pointed line. And if it's in the more palmar aspect where they usually start, and that's the one you should not miss when you take X-rays, it's the other angle. And in practice, this looks like this is the standard more or less 10% view. Then you will have the distance from your sesamoid bones to the joint space short. And if you use the other angle to highlight the palmar or plantar aspect, you will have a greater distance from your sesamoid bone. And then you might pick up also subtle lesions there. That's definitely worthwhile to try. The other thing you can pick up if you look carefully, sometimes there can be some comminution with those fractures, as it's highlighted here, this little triangle. And you can also pick up the displacement. And this is important information as it comes to prognosis of these fractures. Again, it's important to pick up concurrent lesion because they make sometimes even treatment impossible. As you see this one here on the left, this is displaced lateral condylar fracture. But if you look at the space between the sesamoid bones, there's more to the soft tissue damage here, as you can see. And also, sometimes you will pick up, it's unusual, additional fissure lines there, which can be in the sesamoid bone or in the condyle. So it's important to see those. And the bicortical condylar fractures, there is a simple principle of how to want to treat it. They respond best to lag screw fixation and to restore the congruency of the joint space. And this is important, and you should also do this with minimal trauma. That means you do stab incisions and you fix it with lag screws. And the goal is you want to have your correct diagnosis, pick up all concurrent lesions. The second one is you want to have a perfect reduction if it's displaced. And the third one, you want to have an optimal screw placement. I give you some details on this as well. So the situation, if it's displaced, you can see it arthroscopically. And at the end of the day, if you are successful, you don't want to see that fracture gap anymore arthroscopically. And to pick up pathology in the joint, the best way is for this disease, if you put your scope in while you're screwing that, if you're fixing that fracture with screws. And you can even do that in non-displaced fractures, and you realize sometimes you see quite important pathology that lessens the prognosis. And there's always this discussion. Traditionally, it's recommended to do this in lateral recumbency. And because you have a direct visualization to your problem, you can manipulate displaced fractures. You can have an optimal situation for screw placement, and you can use your arthroscope for evaluating the joint and evaluating your reduction if necessary. There's more and more people that do this standing in standing position. I'm not one of those, but the number one reason you want to avoid risk of recovery. This might be true for some propagating fractures in the hind limbs, but that's not the majority of the fractures. And people say that's cheaper. That also might be true, but I always question a little bit the quality of repair in terms of screw placement. Is it comparable if you do standing or in lateral recumbency? So I'm more towards lateral recumbency, and this is the setup. You do a nice preparation of your area, and then the first of all is you use reduction forceps. And if you see a gap there, you try to reduce it and you monitor your reduction. And this is number one. And this is where you want to use your first screw here, is in the middle of this groove where the collateral ligament originates. And this is basically the center of rotation of this joint. And you can palpate this with the condyle, the end of the condyle, and also you're using the P1, the proximal palmar or plantar aspect of it. That was the wrong one. Yes, and then you use any guide, any help to make sure these needles go in the right direction. If you look perpendicular, if you look it on a DP and on the lateromedial view, spinal needle is useful to get your horizontal. And also, I quite like to need these staples here to orientate myself and find out the right spot to do this. And then along with the spinal needle. And also then it's a typical lag screw procedure. So you drill a hole, a glide hole, and then you do a thread hole, and then you tap and screw. This is an example of the reduction of a lateral condylar fracture here. And as I said, this is what makes everybody happy, including the surgeon, if you have a nice reduction and a good squeeze if you tighten those screws. And also, don't never rely just on a DP view. You always want to see a perfect lateromedial view of the leg as well, so that you are sure these screws are also in the other direction in the right spot. Then, as you see, sometimes you end up with having more bone proximal to it. As you see, it's not completely reduced there, but that's not a problem. Up there, and don't use screws up there. The risk to split this fragment up there is sometimes bigger than the benefit for it. The most important part, you need 2 screws distal. In the distal aspect, that makes the job of reducing the congruency of the joint. Okay, whenever you do surgery, you can have complications, and the specific ones for this treatment is your screws can be too long or too short. And if you look at this one here, the left picture, the second one here, so this, you have to be aware that this is where the screw ends, and then this is not too long, most likely short, and make sure you drill through all this so you are not touching the bone on the other side, because that weakens your screw. The other screw in the middle, the picture, that's definitely a too long screw. And if you are in the in this part here, that's where your ligament is. This is about almost a centimeter too long. That's not what you want. And on the right side, this can happen that you break off your screw head. You can take out this screw, but you lose, specifically, you lose the most important screw by doing this. So be careful, your screw is nicely aligned when you tighten it and fix it. And this is another problem here, too short screw and proximal, the most proximal one is there where you have very thin bone, and the too short screw is also not tight enough, and the reduction you can see from the radiograph is not perfect. This is not a good outcome of your surgery. And this is another one that horse became lame 2 weeks after the procedure. And as you can see on the lateral side, there's quite a lot of soft tissue swelling, but I only show you this procedure, this projection. And if you look at true lateromedial one, you immediately realize, oops, something went wrong. And these screws are angled in a way that they could go into the joint on the other side. So that's dangerous, but it's easier said than done sometimes, because the problem is this fetlock joint has a little bit an outward rotation, and the surgeon, if you have your leg perpendicular, tries to drill perpendicular to the floor. And this angle sometimes leads to this result. Therefore, important is do a good intraoperative imaging and be always precise, having lateromedial projection perfect, DP projection perfect, so you know what you're doing. To give you a little bit an idea about the rehabilitation of just a simple lateral condylar fracture postoperatively, 30 days of stall rest, 30 days of stall rest and hand walking exercise, re-radiograph after 60 days, assess for any problems that you might have, then gradually turn it out, and screw removal is rarely necessary unless you have a problem like an infection or a severe reaction around the screw. And you have to rest those horses long enough to have a good and solid bone healing. It's 270 to 300 days recommended. Now, a little bit about prognosis. If it comes to the incomplete fractures, so it's all the prognosis about bicortical fractures, the one that affect both cortices. Everybody agrees that's a favorable outcome, and depending on the papers that are out, 77 to 90% back to race. The non-displaced one with a complete non-displaced ones, the prognosis is a little bit less according to these papers, and the completely displaced one is even less, is 60%. But it's very difficult to make this comparison of success, because there's some studies are out and they mix also the population and also the kind of fractures they're looking at. But the last one, the propagating one, that has the least prognosis. That's obviously because there's more risk for complications. But that's another important thing. Additional damage in the joint or elsewhere reduces the prognosis of each of those categories here. Therefore, it's recommended, especially for the non-displaced one, using any advanced imaging technology if you want to evaluate this more CT, MRI, or I also recommend doing arthroscopy intraoperatively. Good. There's a special thing here. The ones that are called palmar or plantar fractures, they just affect what the cortex. That's where the lesion or the fracture usually starts. Sometimes you see those only on MRI or on CT, but and it's also the debate is, are these better done conservatively or operatively? I'm stopped as soon as you see a line, because in one study from 40 horses that were treated conservatively, 5 reinsured and 1 out of 40 had a catastrophic failure at exactly this spot. So I think that's worthwhile to recommend placing one screw. And if you place this screw, you want to be a little bit closer to where it happened. And therefore, that's a little bit more difficult because you can't feel this groove where you want to place your needle. You are go a little bit offset. And for this reason, I would recommend using kind of an aiming device, so to be more precise in both directions, because you're working closer to the joint space. Now, propagating propagating fracture lines, they usually occur in the hind limb and on medial condylar fracture. That's a typical one, but they can also occur in lateral ones and also in the forelimb. So you look out of those. It's rare if it's others, but it can happen. And you see, you can hopefully spot those lines. They just go more or less parallel, diverge a little bit in the cannon bone, do more or less, and you can see more or less of those lines. And these are the ones you have to treat separate, especially. The current recommendation is still use your 2 screws distal to it to fix the joint and reduce the joint. And then you can use an implant, a locking plate, locking plate technique with locking screws to fix it. Some people also started to using just every other screw, not the full plate filling, but there is a variety on this. But generally, more or less, everybody agrees that this plate helps to prevent catastrophic failure. And this is a case that can illustrate this. This was not a racehorse. This was a 3-day eventer. And I pointed it out with the black lines. We saw just these tiny lines, no displacement of the fracture. Obviously, it was medial condylar fracture with the idea of being displaced. And since we have our computer tomography, it would be useful to understand the configuration of these lines using CT. In some places, you can do this standing. We can't. We have to put it in general anesthesia. And others say these are exactly the fractures you just want to do standing and just put 2 screws or even 3. And this is another important information here, I think. Whenever you use lag screws, you should only use them in an area where you really understand the fracture plane. And I would think in this case, we understand fracture plane from here to here. As soon as they start to spiral, you have to know which line is dorsal and which line is plantar or palmar. There are techniques radiographically. You use staples and try many projections and can figure out which way it goes. You can also cut off the skin when you do surgery and look the periosteum, and then you see those lines as well. But I think that's when we didn't have any other modalities. But this is important when you start treating this. So we made a decision, treated this horse in general anesthesia with the limb uppermost, and then we looked at this configuration. Level A, you could see more or less a sagittal orientation. Level B, the dorsal, on the dorsal aspect, yes, went to laterally. On the medial aspect, even more, the higher you up you came, it's more laterally. So your lag screw should go dorsolaterally to hit the plane. Good. And then this was the plan. And then the other thing is you under tunnel your plates, and then you do it minimally invasively, and you put those in, and then you can do stab incision and put the skins in and squeeze in. And so that's we had a dorsolateral placement of a long plate. That's what we did. The horse was very comfortable throughout. After 3 weeks, just with a bandage, everybody happy, sent the horse home. The next day, a phone call, oh, it's not looking good. Non-weight bearing lame, came back in, and we took that radiograph. So that can tell you two things. Even if you do a standing repair, you are not safe that this will not happen to you in the stable. And the second is, most likely, this plate helped to this horse not to become a complete catastrophic failure. And what we did with this horse, we put him on the table again, put another plate in, minimally invasive, and shortly before Christmas, we took that plate out standing. And now the horse, it's an important broodmare for the lady, so that's why we did all that. But this example should remind you on the fact that condylar spirally fractures remain a challenge. Okay.